Well, hello, and thank you for joining our CMT UK question and answer session. As you know, October is our CMT Awareness Month, and we're aiming to increase awareness and understanding of CMT throughout the UK in the general public, as well as to health professionals. My name is Simon Bull. I am the Chief Executive of CMT UK, and I'm very pleased to be able to introduce Professor Mary Reilly, who is Professor of Neurology at the Department of Neuromuscular Diseases, UCL Queen Square Institute of Neurology, and she is also the patron of CMT UK. Welcome, Mary.
Thank you.
I'm going to go straight to the questions. We have a number of questions that have been sent in by CMT UK members. And the first question, there's three questions here which are kind of linked, so I'll read them all out and let you answer them as you will, Mary. How is the research going? Which Julie is asking. Will there ever be a cure for CMT or for all types of motor sensory neuropathy? And the third question from Katrina is, I have type 1A. What research is being done at the moment? So there's three questions there around research.
Sure. Well, you could spend the next hour answering just one of those questions. So there's a huge amount of research going into CMT because, of course, CMT is the commonest inherited neuromuscular disorder. So compared to every other thing we hear about, CMT is commoner. So although it's a rare disease, there are many more patients with it. And when people talk about research, they're generally asking research towards a treatment, and a treatment that actually treats the disease rather than just the symptoms of the disease. That's mostly what people are asking. And that's what I'll confine what I'm going to say to. There's been a huge amount of advance in treating genetic diseases generally. So years ago, there are things we wouldn't have envisaged that we could do that we can do now. And basically, there's two strands of research in terms of treatment. So the first strand is, if you have a genetic problem, there is a problem in the coding that is your DNA, whether there's a mistake or a bit missing, or you have a little bit of an extra, but there's something wrong in your DNA that gets inherited. And it can be inherited from your parents, or it can start anew, because at some stage, these mistakes that cause diseases start. And the reason we all look different is because we have huge variation in our normal genetic material. So one of the issues when people are looking at the cause of a disease is working out what's just a normal variation, like why do I have curly hair, someone else's straight hair, versus what variation causes a disease. So what can be done now, certainly for other diseases, is already in clinic, is to actually get into the DNA in the appropriate cells and actually correct the defect. Now that's been done in spinal muscular atrophy, or certainly has in practice now. It's been done in other diseases, but including in neuropathy called TTR amyloidosis. So you can actually correct the DNA. In certain diseases, it's easier to do, like in TTR amyloidosis, because the abnormal protein is produced by the liver. So you only have to target the treatment to the liver. In nerves, you have to target it into the nerves in your arms and legs. But there has been a huge amount of progress in that. And there certainly is preclinical models, we call animal models and other models, where there has been successful treatment trials for CMT1A, CMTX1, and more recently CMT4C, and multiple other forms. So that's the genetic therapies. For it to come to clinical trials, and I suspect within the next 18 months, one of those will come to clinical trial. Probably one of them will come to a clinical trial, because we know they're at the stage of doing studies to make sure it's safe. So what they call toxicology studies in normal people before they get to patients. So we're at that very, very advanced stage. The second type of therapies that are developed are not correcting the genetic defect, but correcting what goes wrong when there is a genetic defect. So if there's a genetic defect, it means the protein that's produced by that gene doesn't do its normal function. But sometimes it just doesn't do its function, and you try to substitute the function. Other times it does something it shouldn't do. And there are multiple strands of research in that. And at the moment, there are at least 2 trials ongoing internationally. One is for a compound which is made up of 3 well-known drugs, which reduce the expression of PMP22 for CMT1A. And that's at an international trial, and it's a phase 3 trial. So basically that's a trial that's a very advanced stage, but the final results are not available yet. And that's been going for some years through various stages of the trial. And that's by a company called Pharnex, and I'm sure many patients have heard of that. The second is a much more new trial. It's a gene, a very rare gene called SORD dehydrogenase, that we only discovered in 2020, and the trial started a few months ago. So I think for those of you that have heard us say for years, it takes decades to make a difference. So during the COVID pandemic, a new gene was found for CMT, and a trial has started by the summer of 22. So that's the speed things can happen. Now, that was a little bit fortuitous because the abnormal gene is involved with an enzyme which a lot is known about for other reasons. So that trial is looking at another way. It's not correcting the gene defect, it's correcting the problems the gene defect causes, and that's called SORD neuropathy, another form of CMT. And we're involved in that trial, as are many groups around the world, and that's run by Applied Therapeutics. There are 2 trials that are ongoing at the moment, currently, but there are multiple other ones that I would know of that will certainly be starting during 2023. I do think COVID has put a slight delay. There's a number of things that I think would have started this year or last year, perhaps. But COVID has put a slight delay. That delay hasn't been, all bad, because it's allowed us to be much more trial ready. So certainly in the UK, and I just want to take the opportunity of thanking all the patients that have helped with this. We have multiple natural history studies going as part of international natural history studies and some of our own, to find the best way of measuring change if somebody has a drug. As many of you will know, that it's quite difficult to notice a difference year by year, but you might notice a difference over multiple years. And we have developed a range of clinical measures and a range of what we call biomarkers, which are changes which map to you getting worse clinically, but which we can measure much easier. We have one that we can measure in blood now, and we've been able to do that routinely in clinic here since August, and that's plasma neurofilament level. And we have an MRI biomarker which measures the fat in your muscle, which what happens when the nerve to the muscle doesn't work. So we now are confident, and actually we've shown this in 5 or 6 forms of CMT, that we can detect change over 12 months, even in the slowest forms of CMT. We can detect change, and therefore we're trial ready. So if there's a drug out there now for almost any form of CMT, the rarer forms are more difficult because the numbers are smaller, but we can do a trial. In one rare form, hereditary sensory neuropathy type 1, we're just about to start a trial in the UK of serine. And again, the numbers are small, but we've been able to design the trial to do with 50 people. So the trials have started. Some are planned within the next year or 2. And, I think for those out there, whatever form you have, it's always worth checking what's happening. It's obviously the commoner ones usually are first, but SORD neuropathy is rare compared to some of the other forms of CMT. And yet there's a trial already ongoing because there was a drug that could be repurposed. When people say they're repurposed, it means you have a drug you use for something else and you find it might work for CMT, so you repurpose it. So it's a very exciting time. And I'm aware every time I talk to patients, we say that and they say, yeah, but you said that 5 years ago, and you said that 10 years ago, and you're always saying that. But I do think genuinely there are trials ongoing, and there's been a huge step change in how we can treat genetic diseases. And I think those of you that have seen spinal muscle atrophy, children died before 1 year of age commonly, or within a couple of years, now that there are treatments, and it's early days, but children are doing much, much better many years into it. So I think it is a very exciting time. It's with CMT because most forms are lifelong, that is, they do not shorten the lifespan. There's a much higher barrier of safety to get over before a drug will ever be licensed. It has to be absolutely safe because these are not a fatal condition. If you have a condition that you will die from unless you have a treatment, the risks of taking the treatment can be weighed against the risks of not taking the treatment. With CMT, we must make sure any drugs developed are safe. So I think that's the very, hopeful. I think one of the things to say is most of these drugs that start in trials will be in adults, because for safety reasons, they often do it in adults. Not all, but most. Whereas we know, and all of you out there that have CMT know, that really you'd like to treat as early as the signs show, or to prevent the signs showing. So really in the future, we'd like to be treating people as soon as they have any chance of getting the disease, so very, very early, as soon as we can detect it, which is often in childhood. But that step takes a little bit longer. There will be some forms that will be started in childhood. So that's just a very brief overview. There's lots of other research going on in therapies, in orthotics, multiple other things, but I think that's really what people are generally asking me when they're asking about research.
So there's a great deal going on, and as you say, it's an exciting time, and hopefully we will see progress in the next few years.
Yes, I think it's very exciting. And I think, you know, I would say to patients, you deserve a diagnosis, because you cannot get into a clinical trial without a diagnosis. So we looked at our own practice here, and we now make a diagnosis in 77% of people that come to clinic. That's still 23% of people we don't have the genes for, but it's much, much higher than it was years ago. And the UK has now a national system of testing. So wherever you are in England, sorry, it's slightly different in Wales, Scotland, Northern Ireland. This is Genomics England, but they're very similar. If you go in to see anyone anywhere that does the genetic test, the same test gets done. There's a panel of genes. Whether you get it done in London, in Leeds, in Birmingham, in Exeter, the same panel of tests are done. So that's made it much easier for patients, because they don't have to keep going around to different clinics to get the different tests. Now, research testing is different. That is done in specialized laboratories. But from the NHS point of view, there's a very good panel of tests available. And I would say it's equal to anywhere, if not better than anywhere in the world. And I can barely believe I can say this is such good news. It's much quicker. So the results are coming through much, much quicker than they were even a few years ago. And that's really been a change in the last year, year and a half. So if you haven't got a genetic diagnosis, if you haven't been seen for some years, push it. You should get back. And there's multiple clinics around the country that will do it. And because I think treatments are coming, and certainly trials are coming, and you cannot get into a trial unless you have a genetic diagnosis.
I think we have a question, I think coming up, somebody's saying, do they need to get to know exactly what type they have it? And,
yes.
And
so you need to know exactly what type, because there's about 130 different genes, and all of them cause a different type of CMT. So the vast majority of treatments are gene specific. They're for one gene, but occasionally there's a group of drugs also being developed at the preclinical stage now that, you know, may come to trial in the next 3 or 4 years, which may deal with more than one type of CMT. That obviously would be very attractive, but they're probably slightly further down the line. But you will need to know that, you know, a clinical diagnosis of CMT will not be enough. You need to have a genetic diagnosis. Even if there's 2 or 3 types being treated, you still need a genetic diagnosis. And part of that is, you know, these therapies, when they come in, we know from the therapies that have been developed. So the genetic therapies that we're now using. So this morning in clinic, I had 3 people on gene therapy. So those therapies cost hundreds of £1,000s a year per patient. Now that's fine, but you can imagine you're not going to get it unless you have the right disease. So it definitely will need the right diagnosis to get the treatments.
Right. Okay, so the next question I have is from somebody who has inherited late onset peripheral neuropathy. How should I live on a daily basis? And can you recommend any food or supplements? And what sort of exercise should they be doing daily?
So that's a very specific question that I wouldn't answer, because it's different for every person. But you can say that there are no specific supplements or foods, nothing specific recommended for CMT. You just should eat and live healthily like you would if you didn't have CMT. If you're vegan or vegetarian, you need to make sure you don't get B12 deficiency. So I think, you know, it's not that there's anything wrong with being vegan or vegetarian, and many people that have been brought up that way don't get B12 deficiency. But if people become vegetarian or vegan, sometimes their systems don't absorb B12 as well, or, you know, maybe they're not as good at sorting out the foods. So you don't need any other cause of neuropathy. So we would always say, have a careful balanced diet. If you do anything unusual in your diet, make sure that you have all the supplements. But there's no evidence that taking extra supplements will help. And I'm very against things that we don't know how they're made. So if you get a drug, there's very strict regulations on how the drug is made. Whereas if you start getting stuff from other sources, you don't always know how they're made. So, you know, the thing. In terms of exercise, again, it depends, you know, there'll be a different answer for someone who's very disabled using sticks, for someone who's hardly any weakness in their toes. So again, it'll be whatever, you know, there's nothing you cannot do. I would say that many people with CMT have feet problem, and probably running doesn't suit most people with CMT. Now, I do have patients that run, but, you know, if patients have had little fractures ever in their feet before, or if they don't feel that well, it may not be the best exercise. Whereas, you know, a bicycle or a stationary bicycle might be better. But again, you know, talk to your physiotherapist or talk to whoever you talk to about exercise. Or if there's nobody, do what your body feels comfortable with, but don't overdo it, and your body will know when it's tired. But keeping fit repeatedly has been shown to help generally with CMT, because overall people move less with CMT than people that don't. And because of that, not unexpectedly, they have a higher BMI. So they tend to have more weight on average, not everyone. And that's harder on the joints. So keeping, you know, at a good body weight, eating healthily, and doing some form of exercise that suits you. I love when people say they swim, because that is a great exercise with no pressure on any of the joints. But of course, there's not always pools available. The access to pools isn't great in this country generally. And it's not always hot enough to go out and swim in the beach, despite the summer being incredibly hot. So I think it depends on whatever suits you, but exercise is important, very important. And younger people don't often worry about it, but it's good to establish something so that when you're older, you have something you enjoy and like doing.
Yeah, yeah. Okay. Question here, in addition to general muscle cramps and fatigue, I am starting to experience what I'm going to describe as short, sharp electric shocks in my legs. Is this a symptom of progression of CMT1, and is there anything I should be doing?
So, that particular question didn't mention what genetic diagnosis. It just said CMT1, so I don't know what form of CMT it is. Mm-hmm. First of all, fatigue is very common in all forms of CMT. Not everybody gets fatigue, but fatigue is common. And it's not entirely understood why, but most of it is due to the fact that there is muscle weakness. So we often find when we look at patients in clinic, they will feel, I'll ask them, where are they weak? And they'll say their feet are weak, and they may have a little bit of weakness in their hands. And when we examine them, that's what we find. But when we do the electrical tests, we sometimes find what I call subclinical weakness. That means there is weakness in the thighs or other muscles that we're not picking up just by examining you on the bed. But of course, if you walked 2 miles, of course you'd notice it. So it's very common for people to walk and then get a heaviness of their legs, or they feel they've done a marathon when they walked a few miles. So I think there's definitely fatigue from muscles that are not working properly. I think that's very clearly one of the issues. And then sometimes other people get fatigue if they're not sleeping well and they have any problems with sleeping apnea. You can get sleep apnea. It's rare in most forms of CMT. But if someone is constantly going to bed, they may snore a lot or have difficulty sleeping, and then they wake up unrefreshed and sleep during the day. They sometimes can have sleep apnea. Now, as I say, it's rare, but if someone has it, it's a common cause of fatigue and can be corrected. And you know, the problem is it's so multifactorial. There isn't any specific answer for fatigue. And you know, there are things like if it is sleep apnea, you can help it. And sometimes people may have other causes of fatigue, which makes it worse. But people have to learn, if they have fatigue, if they feel they don't have the equivalent energy of someone same age, same sex, doing the same job as them, I think it's very important to learn to pace yourselves. And occupational therapists are very good at advising that. And I would say I'm probably the worst person in the world at pacing myself. But it's, you know, if you have a really important family occasion coming up or something that you need to be on the ball for, so you're not, you know, you need to prioritize that and not be wrecked from the day before. So it's actually trying to pace yourself to do the things you really enjoy doing. And to accept help with things that are kind of boring. You know, sometimes people will say, I don't want help, I don't need it. And you see them struggle to do something for 15 minutes that they could have done with 2 minutes with help, and then spent the other 13 minutes doing something they really enjoyed. So it's a balance of working out what is your priority you want to do. Now, not everyone has fatigue, but I have to say it's a very common complaint. And my honest opinion from seeing lots and lots of patients, it's generally the muscle weakness that's causing the fatigue. And some of the muscle weakness is subclinical. It's not stuff we see or we measure, But when we start doing EMG and scans, we see that there's muscles affected, minor affected, but enough that you pick them out if you stress the muscles. And many patients quite rightly point out, you see me in clinic, you examine me for what, 20, 25 minutes? That's just a static one-off. You haven't seen me in the morning, in the evening, what I'm like throughout the day, when things can be much, much more difficult. And many of you will know that if you do something, for instance, if you're cooking in the kitchen, you're not probably as good with your hands when you're tired. So if you get tired, you're a little clumsy and you do things, you may not be as good at the end of the day. So I think and that's what I understand by fatigue. Most people, some people have a more overwhelming fatigue. And, you know, occasionally people understandably get very frustrated with CMT. So I had a patient I saw fairly recently who was very elderly, and he found dealing with the diagnosis of CMT in his 70s very difficult, and has had counselling for it. So I think different people, you do see some people getting depressed with CMT. Many people don't, but it is a condition which, you know, affects your life. It may not limit what you want to do in many ways, but it can affect your life. And if people become a little depressed, that can make them more fatigued as well. Again, not common, but we do see it. So I think if someone is fatigued, it's important to find out why. And then finally, I would say about fatigue is, just because you have CMT doesn't mean you don't get other problems. Now, hopefully you won't. But, you know, it's sometimes people feel that every single thing they can complain of gets put down to their CMT. And we find that people are missed with other problems that are treatable because they've CMT. So I think it's to learn not to take no for an answer. If you have a symptom, you need to understand why you have the symptom, and you need to find out. So if somebody you're not happy with an answer, get another opinion.
What about the short, sharp electric shocks in the legs? Is that?
Yeah, I mean, again, very difficult to answer that without knowing the subtype. So there is one particular, there's a, you know, short, sharp electric shock-like pains are not common in the common forms of CMT, but you do occasionally get them.
Right.
They are common in some of the rare forms of CMT, extremely common in HSN1. You do see it with CMT1B due to myelin encoding 0, and you do see it in CMTX1 due to JGB1 occasionally. But there's a big but here. Most people who have a sensation problem with CMT, it's lack of sensation. It's more not being able to feel than having the short, sharp pains. If you get the short, sharp pains, it doesn't mean it's getting worse. So nerves that don't work can either go numb or they can give you pain, but one isn't worse than the other. But it is much more common to get short, sharp pains with non-genetic neuropathies, the commonest one being diabetic neuropathy. So I would always say to my patients, if you've had CMT for years and you suddenly start getting short, sharp pains, people need to check you for other causes, like vitamin deficiencies. Absolutely. It's not common enough to say it's probably due to CMT, although it can be due to it, but it does need to be looked at for other causes.
Right. Okay. So get that checked out.
I think get it checked out. If someone has described it very, very, someone said, as well as the muscle cramps and fatigues, they're beginning to get that. The muscle cramps can be common in forms of CMT because, again, it's because the muscles aren't working properly. But if the sharp electric shocks are new, that needs to get checked out. And the commonest cause of that due to neuropathy is diabetes.
Right. Okay. Thank you. We've got a couple of questions here that are linked. First one, our son, who's 13, has CMT and also developed scoliosis and episodes of extreme fatigue and migraines. Should the treatment care of CMT patients incorporate more management and support of symptoms like this, rather than just focusing on the apparent physical issues? And the second question, which I have scoliosis as well as type 1A CMT, not mild symptoms. I've had operations on my feet. I've always been treated separately, that is, neurologist for the CMT and spinal for the scoliosis. Is that right?
So there's a lot of questions there. And first of all, I'm not a pediatrician. So, you know, I see patients over the age of 16. So anything I say about children is, you know, based on what other people do. So CMT does not cause migraine. So that's a separate condition.
Yes.
So migraine is very common and it can be very troublesome. I completely agree with that. But CMT is not associated with migraine. But, you know, you'll meet people who have CMT and migraine because migraine is so common You're
Yeah.
bound to have some people that have CMT migraine. So migraine, of course, is lots of good treatments available for migraine, lots of very good treatments. And if migraine is a problem for your son, that needs to be sorted out. That's a separate issue. Scoliosis, extreme fatigue, as I say, can happen with a migraine attack. You can have very severe fatigue with a migraine, but it can be part of the CMT. I think when you talk about the management of your son, you know, the migraine is separate from the CMT. It could well be that a pediatric neurologist will manage both if they're a general pediatric neurologist. Sometimes if you're seeing a CMT specialist, they won't manage migraine. So it does vary in different parts of the country with different people where they see them. In terms of scoliosis, now that can happen in all forms of CMT, and you know, it can happen in any form. And what is thought to be the cause of it is because your muscles, even some of them that you think are strong, may not be completely normal, that as you grow, particularly in the teenage years, and I know your son is 13, it is not uncommon when you have a growth spurt, particularly some people can grow a foot in a year, to develop scoliosis. And that's where there's a curvature of the spine, either in one direction scoliosis or another direction called kyphosis. And often you see kyphoscoliosis. Now, that has to be managed a combination of a CMT specialist, now be that a pediatric neurologist or an adult neurologist or a rehabilitation, we have different people, but also an orthopedic surgeon or a spinal surgeon. Many people don't need surgery, some people do. And the way that's monitored is generally done by the surgeons or by joint clinics between the surgeons and pediatric neurologists. And they measure the angle of the spine. And if it's felt that it needs surgery while growing, that is done, but a surgeon needs to be involved in that decision. So it cannot be just one person managing all that. It is a surgical decision. Okay? But I would say that there should be one primary person looking after someone's CMT, particularly in teenagers when they're growing. So that may be the neurologist, and they will involve the orthopedic surgeon or involve the feet surgeon or involve other people. But there's like one conductor of the orchestra, if you want to put it that way. There should be one person keeping an overall eye. And I know there'll be people out there saying, you know, what am I talking about? It takes 2 years to get an appointment with this and 1 year. And it's particularly bad post-COVID for patients with CMT because there's a lot of really urgent stuff piled up. And CMT, you know, the waiting lists have got much longer. So I appreciate that what I'm saying is, you know, maybe not the reality for a lot of patients, that they feel one person's looking after one bit of them, another person's looking after the other bit of them. Of course, a GP has overall care of patients, and you know, there's some brilliant GPs out there and some brilliant practices, but I know they're under huge pressure as well. And many patients say, including one of my patients in clinic this morning, say it's very frustrating. You go to the GP, there's 20 GPs in the practice. Every time I see a new one, they don't know anything about my disease. So I understand how frustrating it is, and that some people feel there isn't someone overall in charge of them. And I would love to see named GPs per patient back. I would love to see, you know, a better system of care. But, you know, despite what's happened in our politics and economics in the last month or two, I think we need a lot more stability before we can see things growing in that direction to have more personalized care from GPs, etc. But I think one person in charge is ideal, and that person will vary who's the best person, but with multiple other people need to be called in at various occasions, particularly with decisions about surgery. And I think with teenagers, it's a particularly difficult time because we would see them when they turn 16. And that's quite difficult because they suddenly have to go from being under a very loving pediatric practice often. It's not that we're not nice as adults, but we're dealing with many more patients coming through in a much quicker fashion. And they've gone from a very child-friendly environment that thinks of their education, that thinks of many different things, to with parents very much the focus of discussion, to being very independent and adult. And in those years, 16 to 18 to 19 can be quite tricky. And often children of that age need more support. I would say boys particularly can sometimes just lose interest in their disease for some of the critical years in the late teenagers. They're just, you know, not interested. And that's actually can be quite important if you're trying to get people to keep fit or to do their exercises, etc. And when people go and see, I think children, teenagers, and you go and see a physiotherapist and they give you a range of exercises, you know, I really wonder how long and how often, how good people do them. And we all know what we're like. If we're told to do something exercise-wise, or we're told we should do something. And people can be very good for a while. Some people are very good all of the time. The truth is, most people do it a bit of the time, and encouragement is needed. So I think, you know, I'm sorry that people are having trouble with that feeling that there's a disconnect. And there is, but there should be one person in charge, but I know that's not always present.
Okay. The next question is I seem to suffer with UTI problems, and some say it's connected with CMT1A. Is there a particular antibiotic, or is that an individual case?
So UTIs are not associated with CMT1A. Full stop. Certain forms of CMT1A does not generally affect passing water or bowel motion, so urinary function or bowel function. Certain forms of CMT that are more severe can mean that there's an urgency, people need to pass water more often or may not clear it as well and are more prone to urinary tract infections. So yes, with certain forms of CMT, you may see that. With CMT1A, you shouldn't. So if someone's getting recurrent UTIs, it's probably not the CMT1A. They need to sort out why they're getting recurrent CMTIs. I will not comment on antibiotics. That depends on which bug you have. It's multiple different antibiotics. You need to get samples taken and they need to grow to make sure you're on the right one, because most GPs now won't blindly give you antibiotics, or they'll give you one, and then if that doesn't work, they'll screen the urine for it. I think if someone is having recurrent UTIs and they've CMT1A, unless it's a very unusual form of CMT1A, that's not the cause of the UTIs. Very unlikely to be.
Right. Okay. The next question here looks like they're from a student. What would you say are the 3 most important things that you would highlight to a student occupational therapist about how they should be looking to support somebody with CMT?
Oh, I'd love to have seen that question in advance. It's a tricky one.
Yeah.
So I would say occupational therapists, because occupational therapists have a phenomenal role to play, but they are even rarer than physiotherapists, I think, to get to see one throughout the country. So I think, the first thing is, I think, CMT affects the legs and feet first. So I think, it varies in different parts of the country who is most involved with helping people walk, be it with splints, be it orthosis. And it's often physiotherapists or orthotists, etc. So I think it's to work out, but occupational therapists can be involved. For instance, if somebody has mobility problems, and I think one of the big areas in occupational therapists that I would see the involvement with CMT is the house. When people move houses and they may have some mobility problems and they're getting rid of stairs, is getting in there early to see, is this the right environment? Is it optimum? What changes should you do to make it better for you? So that's the first thing to say. And the second thing is, I think occupational therapists are the best at managing hand function. And I think as doctors, generally, we're not as good as we should be at thinking about it. So we're great at thinking of legs because people present with legs, but often people use their hands more. And in more severe forms of disease, or a disease gets a little worse, it is the hand function that really troubles people. And occupational therapists have all kinds of ways they can help the hand function, from various kinds of splints, from all kinds of just ways of doing things, giving advice and etc. And I had a patient at clinic this morning who was amazing. He knew he could drive very easily, and he knew he could use the key in his house and his car, but it's just a difficulty with getting keys or just turning them. And it was actually in a forge. He got someone to make something, which is something that he just got made, that you can slip the key into, just gives him a bigger area to hold to do it. So that's the kind of thing occupational therapists do very, very well. But patients are amazing at thinking of their own solutions, because they know exactly what they need. So I think that's the second area that occupational therapists can be very helpful in. And the third area, which I've seen occupational therapists be extremely helpful in, is really in helping people pick or change the right jobs. And there's often clinics about, sometimes it's picking the right career. And that may not be at the stage occupational therapists are involved in, but then it's if people need to change jobs because of their disability, it's helping them make a decision that's something they can do. I mean, for some reason, we notice in clinic, a lot of patients sometimes end up picking the wrong career earlier on, or they pick something that you think, I really wish you hadn't picked that particular career, because I predict that in 10 years' time, that would be really difficult. Now, the number of my patients who use scaffolding and are builders, I think that's, it might be fine now, but what about in your mid-30s, if you don't like going up on scaffolding, or if your foot drop feels you don't want to do it, you need to get the next career choice. An occupational therapist can be very good at advising that and steering people towards it. Because most people want to work. They don't want, if they can't do what they were doing, to do nothing. So that's another area where occupational therapists can be very helpful. So I think the right adjustments for movement, be that in houses, wheelchairs, etc., but that's rare and it's more severe. Hand function, I think occupational therapists are really good at, and we don't think of it enough. We don't, we can see leg problems as you see someone walk. We don't see the hand problems. So we need to listen more. And I think there's lots of things that can be done for that. And thirdly, it's career choices at the critical times. It's people making the correct career choices and helping them see there are other possibilities. And now, computer work, and I think the whole way work has changed, the way we work in the last 3 or 4 years, is it revolutionized really how work can be done. But not everyone wants to work from home just because they can. They may like the social side of it, etc. So I think they're the 3 areas I would say, without having had time to think about it, and it may not be the answer you were thinking about it.
Okay. Thank you. Here's another one. That is it the CMT, or is it just another cause? Does CMT1A cause tinnitus or deafness?
So I think that's a good question. So first of all, the nerves to the ears are partially nerves made up of the myelin that you find in the nerves in the arms and legs, and partially of the myelin you find in the brain. So you can get deafness with CMT. You tend to get it in certain types more than other. And in CMT1A, you tend to get it if it's the more severe end. So it tends to be associated with severity, but sometimes you see it more. You see it more in CMT X1, for instance, than CMT1A. So you can get deafness. The problem with deafness is it's so common, particularly in older ages. There's literally hundreds of genes that cause deafness as well. So often you draw a family tree and someone will say, I'm deaf and I have CMT. And you realize there's one side that has CMT and another side that has deafness. So yes, you can get them associated, and they can be due to nerve damage, but there are multiple other causes. But the treatment is the same in terms of the deafness. It is hearing aids if you really need them. So there's no difference in the treatment of deafness, but yes, you can get it. And sometimes you can get tinnitus with deafness, not so commonly with CMT, but with any kind of deafness, you can get tinnitus sometimes.
And of course, you can get tinnitus without deafness.
You can get tinnitus without deafness. Now, that's more common due to noise damage to ears, but there's thousands of causes of tinnitus. Yeah. Literally many ears disease, multiple other causes. So again, bad tinnitus is pretty unusual with CMT, but you can see deafness. Okay. Bad tinnitus is pretty unusual.
Okay. Is there any point in asking one's sons, daughters to be tested for CMT? Oh, this is the one I was talking about, since there's no treatment or cure available for it.
So I think that's a very important question, actually. And again, with another conditioning clinic this morning, I was having a conversation with patients because things have changed. So I think, first of all, if you have CMT, it's you that decides when to tell your family. Nobody else does. Nobody will contact your children. But we normally find the children want to know, particularly when they start hitting 17, 18, 19, when they're going on their own individual ways, making the decisions. People will want to know if they have a risk. So if they have a risk, so the common form of CMT, like CMT1A, children will have a 50% risk of inheriting the gene. And they may have shown signs well before the teenage years or not, but they will want to know. And at the moment in the UK, the guidance is that you normally don't test children who have no symptoms or signs at all. You would only usually test them if they have symptoms or signs, because then that will influence their treatment, or if they want to be tested once they turn 18 and it's their own decision. That's normal practice. Now, there are exceptions to all of this, but that's what normally happens. And at the moment, you're absolutely correct, because there's no curative treatment. There's no particular advantage to someone to know. Now, the minute there's a treatment, that changes. So in our other disease this morning, I was talking about another neuropathy, we're totally giving different advice now. We're saying the earlier you know, the better, because then we can start treatment earlier. But I think the other time people want to know is when they're thinking of having children. Because if they're thinking of having children, if they're at risk, but they've no signs, they might want to know if they carry the gene, so they can make decisions about their pregnancy, but also be informed of the risks. So I think anybody who's at risk of CMT, I would say, has a right to know about that risk once they turn 18, around that age, if they have no symptoms. So they can then know, they may keep it in their back of the mind and do nothing, but they know if they develop symptoms or if they want to start a family or have any other questions, they will know that they have the possibility and therefore can test in it. If the treatment becomes available for any form of CMT, this will totally change. So some of the severe childhood diseases now that are treatable, that weren't, there's an argument happening, and it has changed in certain places, not in the UK, where they'll be screened at birth. You know, the way at the moment when babies are born, certain diseases are screened for because they're treatable. That may change if we have things that are treatable, because it may be that it's important. I'm not saying it's going to happen right now, but we know with CMT1A, for instance, you know, most people, and I'm sure people in the audience will know this, get their symptoms in the first or second decade. But once they get their first symptom, if they look back, they might have been the slowest at races, or they may have been a bit clumsy, but not thought it was abnormal. We actually know that if you do electrical studies at birth in patients with CMT1A, there's already abnormalities in the electrical studies. So we know that the abnormalities are there from the very beginning. So if we had an effective treatment, we'd want to start it as early as possible to prevent any damage to the nerves. Now that's way down the line, but treatments change decisions.
Yeah. Okay. Next question is asking, why is my leg below the knee so much colder than above my knee?
So in terms of that question, it's a very good question. And patients constantly say to us, my legs feel colder the further down you go, and my symptoms are worse in the cold. They feel number, or I have, you know, less feeling in the cold. And some people think that must mean there's a problem with the circulation. People will often say I have a circulation problem. So cold, the feeling of coldness and the worsening of symptoms in the cold is due to the sensory neuropathy. It's due to the lack of sensation to the skin, because the nerves, not only, you know, they're very important for actually feeling and for moving, but also when you move, the circulation is all involved in that. And you have these tiny little nerve fibers, which are important for the circulation in the blood vessels. So that is part of CMT, that you're worse in the cold, that the symptoms are worse in the cold. And some patients say it's much worse in the cold. And if it isn't cold, that they feel colder. So it's part of the fact that the sensation is not normal, that the legs do feel colder and are colder often when you touch them. But it doesn't mean that it doesn't mean there's a major circulation problem. It is seen with neuropathy. It is something that's seen with neuropathy.
Okay. Moving on, I've got a patient here. This particular patient has one CMT1F, but they're asking where they can find specific information relating to the different types. So where can she or he find out more about?
Yeah, so 1F is due to a gene called neurofilament light chain. I tend to use the gene name now because it's, you know, there's so many different forms of CMT. 1F, there's two SS now as well. So I tend to use the gene. And so we've written a paper on that about 3 or 4 years ago on a collection of patients. So we do have, I don't know how many patients without looking it up I have with neurofilament light chain, but I would have about 20 to 25, so quite a number of patients. And there is research going into that, as there is in other ones. It's a more complex protein because this protein is involved in the axon. It's a very important protein in the axon. But yes, there is research going into it. There is the specific information on this. There is specific information out there in terms of the kind of symptoms it causes. But most forms of CMT still cause, you know, distal wasting and weakness. That is wasting and weakness worse in your feet first and then spreading off, and distal sensory loss. And neurofilament light chain is more or less the same. There's certain things I think you see more commonly with it. I think people tend to be often a little bit more unsteady with it than other forms of it. I mean, there are differences you see, and it's often more difficult for a diagnosis to be made because the electrical studies can be confusing for doctors to interpret. But there is research gone into it. There is no trial about to start in it at the moment that I know of, but I do know of research going on into neurofilament light chain, which is 1F. It's confusing because it can also be called CMT2 because it can cause electrics that are in between. That's why I think it's easier to stick to the gene name because it gets all kinds of complicated. People can argue for hours about names.
All right. So is there somewhere, somebody has a type of CMT, is there somewhere they should start, if they're interested in symptoms and finding out, is there somewhere they can go to? We try and put out stuff.
Yeah, so I think you have a very good website. I mean, there are multiple different websites with the CMT, and I think CMTUK, CMTA in the States is a very good website as well. We're part of a large group called the Inherited Neuropathy Consortium, and on that there's a very good patient and portal that goes into all the different types of CMT as well, which gives information. So I think, there is a lot of information out there. And I think, the CMTUK is probably certainly the best place to start with looking for it because you tend to have the links to all of them. Because I think the problem is if you Google CMT, first of all, you won't get CMT, you have to put in Charcot-Marie-Tooth. If you Google it or start looking at it, there's just so much information out there. But I think some of the best initial searches are done through the organizations like CMTUK, Muscular Dystrophy UK, CMTA, as I said, the one in the US. They're the one that, because basically most of them have the links to all of our more detailed stuff as well.
Yes, if you Google CMT, you'll tend to get country music stuff to start with, so you have to be a bit careful.
Exactly.
Okay. I get trigger finger in both hands, excruciating nerve pain in the forearm, coupled with the index finger being locked down. This usually eases off after about a minute. Is this linked to CMT?
Again, as you know from when I do these, I can never respond to an individual question like that without seeing someone. It is almost impossible. Trigger finger as such is not linked to CMT usually. It is linked to other forms of neuropathy if it's genuine trigger finger. But cramps that look like trigger finger are very common in CMT. So people think of cramps as a painful muscle, and it usually is. But in the hands particularly, you can get, your hand can do something like this, and that's actually a cramp, not a trigger finger, but it may be painless. And that is due to the electrical supply to the muscles not working properly. And sometimes it just cramps up. It's like a charge of electricity not working. So you do see what looks like trigger finger, which I would call painful or painless. And I know this one was painful in CMT, but there are other causes of trigger finger which are not to do with CMT. So it's difficult to comment on just one, but it could be, that sounds like it could be a cramp because it's very, very painful. The description of the index finger locking down, that could be a cramp. And there are certain forms of CMT that's more common in. There are certain forms of CMT, particularly one very rare form that's more common in. So it could be, it's difficult to say from that description.
Okay. This next question, I know we've had a conversation about prescription drugs and which ones to avoid and whether there should be a list and whatever, but this question is asking, are there any prescription drugs best avoided? For example, beta blockers, SSRIs, etc. That's Jim asking that.
I mean, I think that's a very good question. And, we get asked this the whole time, not just by patients, but by other doctors, including this week. There's only one drug really that's absolutely proven to make CMT worse. And that's a drug called vincristine, which is used for chemotherapy, which I hope nobody will need. Now, sometimes, and it's for CMT1A, it can make it worse. Now, sometimes people need it. The oncologist will always try to use a different drug, but that's the absolute one that's proven. Everything else isn't proven, but there's multiple drugs out there that can cause a neuropathy, even if you don't have CMT. So there's lots of drugs that can cause a neuropathy, but you won't be more likely to get the neuropathy just because you have CMT. But if you have CMT and you're going to be given a drug that could cause a neuropathy, you'd want to see, is there an equivalent drug that's just as good that doesn't cause neuropathy? So that's more what patients ask. So most drugs do not make CMT worse. But certain drugs can also cause a neuropathy as a side effect. And you should try to avoid those if you can, but sometimes you can't. Sometimes it's a balance of risks. So there's not a big list out there, because the only drug I tell people to avoid is this drug, vincristine, unless it's absolutely necessary, and then it would be a discussion between me and their oncologist. The rest of them, people ask us all the time about statins, for instance. I mean, some in the literature, it says very rarely statins can cause a neuropathy. I have never seen statins cause a neuropathy in patients with CMT. So, it's most people tolerate it extremely well. It can cause muscle symptoms in any people, whether they have CMT or not. So we wouldn't avoid a statin, for instance, which is a very common question we're asked. The statins are used so commonly. Beta blockers wouldn't be avoided either. Beta blockers sometimes are, sometimes people take them for the tremor they can get with CMT. So there's nothing there's nothing we would say that absolutely needs to be avoided, with some very, very minor exceptions. But it's just that if there's an equivalent drug just as good that doesn't potentially cause neuropathy, that should be looked at. But it's a balance of what you need. So it's an individual discussion for each drug with each patient. But overall, most drugs, the vast majority of drugs, do not make CMT worse, or there's never been any evidence. And CMT is common enough that we do have a lot of evidence about that.
Okay, thank you. Next question, are certain strains, types of CMT, prone to more problems with breathing? From Liz.
That's a very good question. It usually comes up, and the answer is yes. So with CMT, it does affect the longest nerves first and worst in most forms, like 1A. So it'll affect the nerves to the legs first. But remember, one of the nerves to your diaphragm is quite long. So basically, people can, as CMT gets worse, sometimes gets a problem with the breathing. It's unusual in CMT 1A, but not heard of. Other forms of CMT, there's a gene called GDAP1. It's more common to have diaphragm problems and breathing problems. So certain forms of CMT, you can have the nerves to the muscles of breathing affected. So it still is a nerve problem, but most you don't. So if somebody feels they've got more breaths than they should do, that they find it difficult to lie flat, that sometimes would tell you there's a diaphragm problem. Or if they have symptoms suggesting sleep apnea, that is, they're snoring a lot at night, or waking up in the morning completely unrefreshed and finding they're falling asleep at all times during the day, then they should get checked out to see if there's any breathing problem. So sleep apnea and diaphragm weakness can occur with CMT, and is definitely more common in some of the rarer forms like mutations or variants in GDAP1. Now there are others.
Okay, thank you. Okay, next question is, hi, I have CMT type 1. I have cervical spondylosis in my neck, and I have a muscle that spasms that makes me want to turn my neck to the right, particularly when I walk, causing pain and discomfort. This person gets Botox from time to time, and they're on amitriptyline and do physio exercises. They wear surgical boots. Is this a common issue with CMT, or is it quite rare? And is there any sort of treatment to help with that?
Again, I couldn't comment on an individual description like this. You just couldn't comment, you'd have to see it. But cervical spondylosis is basically arthritis of the neck, and it's very common. I suspect most of us over the age of 50, if we had a scan done of our neck, there's wear and tear there. And it's called cervical spondylosis. So just because you have CMT, it doesn't mean you're less likely to have it. And in some cases, if you walk badly because of your CMT, you may be more likely to get some degeneration. So we do see cervical spondylosis commonly in CMT, but we see it commonly in all kinds of other people as well. And cervical spondylosis usually presents with tingling or numbness in the hands, often one or the other. So it's a little bit different than CMT. You may have a lot of pain in your neck or pain going into your arms, and there may be certain weaknesses. So that people with CMT sometimes have to have operations of their neck irrespective. The second problem you're describing there is this spasm in the neck that makes you want to turn your neck to the right, particularly when you walk, and they're treating with Botox. Sounds a little bit more like dystonia. It's a slightly different thing. And that's something we don't see with CMT or with cervical spondylosis. So it may be another cause, but of course it could be that you're describing cramps due to cervical spondylosis that they're treating with Botox. And therefore I can't really comment on that. Amitriptyline is a drug that's used for nerve pain, and it's commonly used for people who have nerve pain due to whatever the cause. A lot of people with CMT don't have nerve pain, but some do. And with cervical spondylosis, with muscle pains, one of the drugs used is amitriptyline, but there are multiple other drugs used as well. So I'm sorry not to be able to be more helpful with that. It's just it's slightly difficult to interpret exactly what's going on from what you've written down.
Okay, and I think that probably the last question, how on average, how quickly does CMT progress? My 8-year-old daughter appears to be deteriorating quite rapidly within a short space of time.
Again, very difficult to answer because it depends on the type of CMT. So we've now published internationally in the last few years the natural history of CMT1A, CMT-X1 is just about to come out, CMT1B, and CMT2A. So we know on average how quickly each of those subtypes progress, but it does vary completely between different subtypes. There's no question the slowest progressing form is 1A. So 1A tends to be the slowest progression. 2A sometimes is more progressive in childhood. People can see deterioration more quickly. 1X usually not at that age. So different ones and some of the rare ones can progress quicker. So it's very different for individual types. So it can progress more quickly with certain types. The other thing to say, and it's a concept of usually progression is, it doesn't progress like this and suddenly get worse. It usually is on a trajectory, which could be very slow for most people. But if you start off with 100% of everything working normally, you can usually drop to about 80% and not notice it. So sometimes you're progressing at the same rate, but you're not noticing it. But if you've already got down to say to 30% in one muscle, say in your foot, and you lose another 10%, you're really going to notice that. So that's why a lot of people, for instance, in their 50s, middle age, suddenly think I'm getting much worse. But it's not that the trajectory has got faster, it's that they've less, and therefore when they lose a bit more, 2% from 10% is much more than 2% from 100%. So that's why people sometimes feel that the disease is progressing more than it was, whereas actually it's the same progression, but just there was less to start off with. But as I said, in an 8-year-old, that is, it would depend on the type of CMT, but I think if it's progressing rapidly within a short space of time, I would suggest you talk to the neurologist or pediatrician, whoever's looking after your child, and say, for whatever type of CMT your child has, is this what you would expect, or should they be looking for something else? And if the answer is yes, it's this kind of CMT and we see it, well, then that's an explanation. But if not, they may need to look for something else.
Okay. I could squeeze one more question in if you're happy with that. If you're okay, I'll squeeze this very last one in because I think it's interesting. It kind of continues the theme of our chat today. It's somebody who has CMT, stroke fatigue, type 3 diabetes, PTSD, and chronic pancreatitis. In terms of pain, diet, social mobility, and pain management, how do they differentiate? And I think that's broadly what we've been looking at a lot today.
Yeah, that's a very difficult question. It's not a little short one to finish with. I think if somebody has multiple different, people call them comorbidities, that means they have different things happening at the same time. So stroke can cause problems with the arms and leg and fatigue. CMT, we've talked about. Diabetes clearly can cause multiple problems. Post-traumatic stress disorder, of course, problems. Chronic pancreatitis can cause fatigue, pain, etc. So I think there's two things. The way we would differ, if you came to a clinic, it is difficult because with all those symptoms, you often end up in a clinic for one or the other at any one time. When you have multiple problems like that, obviously your GP would see you with all of them. And sometimes for older patients, a geriatrician or care of the elderly would manage all of them. But it is true that that's the kind of patient that sometimes find everyone is looking after one bit of you and not the other bits of it. So what we would normally do is we differentiate as doctors by taking the history. So we listen carefully to each of the symptoms and work out which of the diseases is causing that. But some of the symptoms, such as pain, such as fatigue, can be caused by all of them. So it can be very difficult. So I would say if someone has multiple comorbidities, the importance is not differentiating which is causing what, but it's managing them. So it's to have a multidisciplinary approach to management. So it's whatever team is trying to manage it is actually concentrating on the symptoms of everything rather than actually working out where everyone comes from. Because in the end of the day, the type of symptoms you're describing are symptoms that need managing rather than individual treatments depending on the disease. And again, I appreciate it can be difficult to get into a proper management. I mean, that's the kind of person that would do very well in a good multidisciplinary team of therapists and pain management.
Right. Okay, well, we've come to the end. Thank you so much, Mary, for giving us your time and for answering all those questions for us. Thank you, everyone who's watching this. Thank you to the CMT UK members who sent in the questions that have been well answered by Professor Reilly. And if you want more information about CMT and about CMT UK, please visit our website, cmt.org.uk. And together we'll help to increase the awareness of CMT, and hopefully by sharing this video and other posts, especially during this awareness month, we can really make sure that more people know about CMT. Thank you so much. Thank you again, Mary.
No problem. Thank you.